Guys, hello. Okay, welcome everyone for the DDU teaching for this week, and we're going to be talking about echo and pregnancy for this one. And again, it's really great to have Prof. McLean, who's with us for joining us for DDU teaching at the moment, who's a cardiologist and also specialises in sort of peripartum echo as well. So thanks for joining us, Prof. We're going to go through a whole bunch of cases. Is the basically why I'm going to do this, and each time I think we'll ask someone else to try and talk a little bit about it, and I'll fire questions at you, and it's meant to be a little bit similar to how it would be in the exam for the Viva scenario. So I guess we're going to work on that this week. When you're talking, I guess from the examiner's point of view, or I guess the way, and correct me if you disagree with this, Prof, but from the examiner's point of view, I guess what we're after when you're trying to describe the Vivas, you know, you've got about, I think it's 40 minutes to talk. We're going to show at least we've got 8 or 9 questions to go through. Generally, it's about between 2 to 5 or 6 minutes per question. We want to try and get a certain pace going through it, but it's a little bit similar to answering Vivas in the SICM exam, where you've got to be talking at the level of a consultant. You know, I think when you're starting off saying, you know, it's a parasternal long axis view, you don't have to go through, you know, it's at 17 centimeters, it's you know, starting at the right ventricle and work your way around. I think you've got to kind of read the situation and try and get to the money pretty quickly, but at the same way having a systematic approach to answering the question. So we'll start having a go with each other, and and we'll give you some feedback as we go, okay? All right, so I guess from the shortness of breath and the echo in pregnancy, you've got to understand that there's going to be a lot of different changes that are going to be going on during the pregnancy, not least from the respiratory changes. First of all, we know that we're going to be getting a reduced chest wall compliance because of increased abdominal pressure. You're going to have a lower esophageal sphincter tone. We're going to have a decreased FRC because of the elevated diaphragm, more risk of edema from vasodilation, and alkalosis with an increased respiratory drive from the pregnancy, and all of that driven because of increased fetal demands in the placenta. We know that you're going to be getting a lot of changes in your tidal ventilation, your respiratory rate, your minute ventilation, your alveolar ventilation that comes on with pregnancy, and of course we're going to be getting corresponding changes during the cardiovascular system with increased cardiac output. So we're often getting sort of hyperdynamic circulations and mild dilations of left atria and things like that. So I'm going to start off with moving to talking about our first case. And this is a case who's in a unit at the moment. And the reason why I invited Prof is because he's been looking after her already. So maybe we'll start off with a 25-year-old lady who got transferred down to us about 3 or 4 days ago from a hospital about a couple of hours away. And she's 25 weeks pregnant. She's got a background history of having antiphospholipid syndrome and also a choriocarcinoma that has left her with a lung lesion on the right lung, which she had a lobectomy for done several years ago. But the main thing I guess we've got to worry about is this antiphospholipid syndrome. She's presented to her GP and then got sent into hospital because she was short of breath. That's been there for a few weeks, and that had got worse. She had a chest x-ray done that suggested that she might have a pneumonia. And this was the chest x-ray that she had when she came in. Everyone can see that. Please let me know if you can't hear me, you can't see anything, okay? So this is the chest x-ray actually when she was sent down to us on non-invasive ventilation with someone saying that they thought that she had a community-acquired pneumonia. I think when we looked at this, we thought that this, you know, was affecting both sides. Agreed, the left side was worse than the right, but it certainly had some features that might be pointing more towards a pulmonary edema side of things rather than just a simple pneumonia. And so we went on and did an echo. So where do we want to start off? Raymond, I've got you top of the screen. I think you're always the person who logs on first, so you're always the first one. I think I made you go first last time. Are you happy to go again this time?
Myself.
Beautiful. Can you see that okay? Do you want me to zoom in on each image in turn, or can you see all 4?
I can see that reasonably well, yep.
Okay, if you need me to stop and just zoom in on one at a time, let us know. So why don't you take us through this? So 25 weeks old, short of breath, 25 weeks pregnant, history of antiphospholipid syndrome.
Okay, so I'm looking here at the personal long axis views, and I do see some left atrial dilatation, just eyeballing there, but I don't want to measure that. I see some posteriorly directed mitral regurgitated jet. that is looking mild at the moment, but I'll again want to quantify that closer. The aortic valve looks fine in long axis. Can I see other views?
Yeah, I am going to zoom in on one thing for you. Let's see if I can zoom in. Tell me a little bit more about that one, because I think that's probably the best picture that we've got.
Okay.
So you said that. So just.
I do.
When you're doing it, I said you go for the money, and I think you did sort of go straight for the money. But just give me a little bit more. Just take me through a bit more of a systematic approach to this. So she's short of breath with what I think is pulmonary edema on the chest X-ray.
Yeah.
So
the suggestion here that there's left atrial hypertension with the left atrium that's dilated, and that's what I'm suspicious of looking at this view. And the reasons why is because I would expect that chamber there to be, a similar size to the aortic root and to the right ventricular dimensions, and it's looking bigger.
Beautiful. What about the left ventricle? So why is the left atrium enlarged? And you said it's the left atrial hypertension. What do you think the raised left atrial pressure is from?
Well, it's hard to say, really. I do see the jet of that microregurgitation, but it looks insufficient to explain the cause of the increase in size in the left atrium. So other causes would include diastolic dysfunction,
Let's work our way back. So work through the mitral valve, or do we even work from the left ventricle? As the size and function.
Diastolic function, mitral pathology.
Okay.
I'm looking for mitral stenosis as well as for mitral regurgitation. The valves seem to be moving well; they're not thickened and calcified, and I don't see the hockey stick appearance of classic rheumatic features.
Okay. What about signs of pulmonary edema? What do you think's going on else? What else have we got? Can we see in here? Particularly down at this bottom. Why am I giving you this? I'm giving you a bit of extra room here, and I'm doing that for a reason.
Yeah, look, I guess it's not coming out too clearly on my screen, but I guess it's a suggestion that there's some fluid in there.
Yeah, it's more the B lines that I was just trying to show you. I think we've got some confluent B lines of them coming in. So again, don't forget that, I guess if someone's got pulmonary edema or there's a story of shortness of breath, we've got to go looking for, B lines, and we've got to go looking for signs of increase interstitial fluid in the lung. Okay. Yeah. Just going to ask you, I'm going to challenge you a little bit on these leaflets here, because she's got pulmonary edema for some reason, and we're going to have a closer look at this. I don't know how it shows up. If I zoom in here, it's not magic. I'll tell you, we'll move on and go and have a look at other views. Keep going, Roman.
Okay, so this is the tricuspid. So this is peritoneal long axis focused on tricuspid valve. Sorry, I'm disorientating myself to the images.
So fair enough. So I guess I'm trying to go through these in a standard way, so that
so that's a tricuspid valve.
There's the RV inflow view, and there's the
not a lot of
Doppler through it.
I'm just trying to work out the third image that I'm struggling with.
And then that's just tilting up, going through the pulmonary valve. So we tilted the probe down to get the RV inflow view, and then we tilted it up to get the pulmonary artery view.
Beautiful. Yeah. So I'm not seeing any abnormal color flow through that, and the profile looks reasonable.
Fantastic. What profile would you expect to see with pulmonary hypertension?
The notched appearance.
Very nice. And if we were to do the pulmonary acceleration time, what would be a cutoff abnormal pulmonary acceleration time pointing towards increased pulmonary vascular resistance?
I don't know. Depends on your sensitivity that you're accepting, but 120 is normal. Maybe less than 100 would be abnormal.
Very nice answer. All right, why don't we skip that one and come on to this one? Raymond, should we just go into Carden? Let's.
Okay. All right. So now I'm seeing some mitral valve pathology here.
Fantastic. Well, I tell you what, you've done a great job. I think just in terms of answering those questions before, I think we need a little bit more information than that in the exam. So again, a nice structured approach, but going for the money. making sure if you've got someone who's got pulmonary edema, we at least mention the left ventricle looks okay, talk about the valves, and I agree they're a bit of a shitty views to begin with. Talking about the left atrial size, and if the left atrial size is enlarged, we've got to be talking about the reasons why that might be there, and then mentioning about signs of increased interstitial fluid. So, that'd be the kind of thought pattern that I think we'd go through clinically if we were dealing with this patient, and the same thing should be verbalized. Don't let the examiner walk away to think that you haven't thought about the left ventricle. So systematic on the money, though. We don't need to learn a lot about the right ventricle probably in this case, or the fact that there's no pericardial effusion. That's obviously not what the question's about. It's about the cause of that pulmonary edema. Cool, thanks, Raymond. Carton, what do you think about this? Take us through this story now. Sorry, just unmuting you, Carton. Hang on a sec. There you go. You're on.
Okay, left ventricle looks dilated, and I suppose the anterior wall motion looks also dyskinetic. The mitral valves are thickened, particularly at the tips, typical of rheumatic disease, with restricted motion with a hockey stick appearance. Left atrium is dilated. There's what appears to be at least moderate mitral regurg on color flow Doppler criteria. And mitral inflow, we're seeing turbulence, really is why we're seeing that. I'm sure you've placed your pulse wave sample window perfectly, but we're seeing a turbulent inflow at the mitral valve inflow, and let me just see what the mean gradient.
Mean gradient's average of around about 9.
9, so that is elevated. You're going to ask me the reference range, and
I
have to check that. We can also see the mitral regurg, a dense mitral regurg jet as well on that inflow. So I would say there is mitral stenosis, there's mitral regurg, dilated left ventricle, odd-looking motion, dyskinetic motion on it, and dilated left atrium. So, and this would be very suspicious of mixed mitral valve disease, typical of rheumatic disease. Now, you said she had, I think, antiphospholipid syndrome was what you told me her history was. Is that right?
Absolutely.
So, I'm not sure if there's a overlay there, but that's really what I'm seeing. So I'm seeing mitral severe, at least moderate, perhaps severe mitral regurg with a dilated, impaired left ventricle, mitral stenosis, mitral regurg, and mixed mitral valve pathology.
Beautiful. Just before I'm going to hand over to Prof to have a grilling for you. So first of all, talk to me about the severity of the mitral stenosis.
Well, I mean, we can eyeball it. So there certainly is restricted motion. You can see that it's not opening up fully, and there's a hockey stick appearance.
Agreed.
So in terms of 2D, we can actually see that. And in terms then, we can then look at the gradient of the inflow and work out mean gradients.
So mean gradient's around about 9.
The 2D, yeah. I'm going to have to look up the criteria. I rarely see mitral stenosis. I see one every 2 years. But I can see a high velocity turbulent jet on the inflow.
Fantastic. So
but also, I mean, there are of course Doppler criteria for grading it as well.
Yeah. So the mean
gradient moderate because I can see motion. I can see it opening and I can see inflow, but I'm making that up, I have to say. I just have to check the reference ranges.
So references are 5 and 10. So it's nice and easy for mitral stenosis. Yeah. So if you're over, for the mean gradient, if you're around about 5, it's mild, 5 to 10 moderate, greater than 10 is severe. Okay.
I'm going to call it moderate to severe, though. I'm going to be careful about using the S word.
Yeah, and why is that? So that's what I just want to focus on a little bit. So what's the problem with this mean gradient, using the mean gradient alone to estimate the severity of the mitral stenosis?
Like any Doppler criteria, it'll depend on the pressure gradient. It'll depend on the pressure gradient that is driving the velocity. We're measuring a velocity, which is dependent on gradients that are forcing it, and we're sort of extrapolating that to, I suppose, to the cross-sectional area of the stenosis. So,
absolutely. So why is that of relevance, particularly to this case?
There's very high left atrial pressure.
Yeah.
There's also probably high left ventricular and filling pressures, so I suspect that the high left atrial pressures, we can see the left atrium is very dilated, bulging into the right atrium at all times. So I think maybe perhaps there's a high left filling gradient that's forcing it through and perhaps just pushing that mean gradient over 10. Because when we see the motion of it on the 2D, there clearly is some opening evident. I think I'd be calling this moderate to severe on that basis.
Moderate to severe. Okay. So why is it particularly relevant to this case? Remember, this is a girl who's 25 weeks pregnant. And you also told me that, I guess the buzzword that I'm looking for is saying it's load dependent, right? Because if you've got someone who's hyperdynamic and the blood's going round and round the circulation much faster, that gradient's going to go up. It's just the same as cardiac output goes at, 4 to 6 when you're at rest. And if you exercise, it can go up to 12 or 18, right?
Yes, good point.
That will make your mean gradient bigger. So if you're undergoing exercise, someone who's got mild stenosis can end up looking like they've got severe stenosis. We call it functional mitral stenosis. So we talk about it being load dependent. So it's very important to take it into clinical context, which we love asking about in the exam. It's all about clinical context this and clinical context that. And in this case, the buzzwords I'd like you to look at is he's got it at 9, that's in the moderate category. I agree on the 2D, it looks like it might be in the moderate category. But she's got two things that are very important to take into context. One is the solid mitral regurgitation that I agree with you looks like it might be moderate, even severe, because it's touching the back wall on color Doppler, and it looks pretty thick here on continuous wave Doppler. And also, she's going to have a raised cardiac output by at least 25% because she's 25 weeks pregnant. So that would force me to think that this might be overestimated. Yeah? So be that kind of that's the kind of thought process you're going to be wanting to sort of think of when they're showing you these questions. Might hand over to Prof to see if he wants to hammer you with anything else as well. What do you think, Prof?
I take your point. You probably don't see a lot of mitral stenosis. And we don't see a lot of mitral stenosis these days, except mainly in immigrants and the indigenous population, of which this woman is neither. However, those mitral valve leaflets are not as calcified and restricted as what you'd normally see in chronic mitral stenosis. I'd be thinking of an alternative diagnosis. There's no doubt they're not opening that well from this view. But secondly, they seem pretty pliable leaflets in other ways, except for the tips.
He's in Fiji.
So, can anyone think of any alternative diagnoses?
Lewis, you're down in Fiji. Are you seeing a lot of mitral stenosis down there?
Yeah, a lot of rheumatic mitral stenosis, actually.
Yeah, tell me, so what do you think? So you've obviously seen rheumatic mitral stenosis. What do you think of this?
It didn't look as classic to me. Initially, my first thought was it looked less rheumatic than some other pathology.
Fantastic. So what other pathology do you think might be of significance here?
So I can't stop thinking about the antiphospholipid syndrome in association with connective tissue disorders, and the question about whether these thickenings are maybe like a Lieberman-Sachs type lesions.
Very nice. Very nice. Just talk us through what is that?
So it's essentially a valvulitis associated with connective tissue disorders, usually lupus. I think lupus is the most common cause. They can mimic vegetations and usually endocarditis, but can also cause valve pathology like this.
Yeah, that's really nice. I think that's exactly what we were thinking as well, is that this didn't have the classic appearance of mitral stenosis, and absolutely with antiphospholipid syndrome, we're dealing with Lieberman-Sachs endocarditis or non-infective infective endocarditis. So in terms...
I've only seen... This is here, that's a...
So while I've got you on the line, Lewis, why don't you help me out with the severity of the mitral regurg? What do you think about the severity of it?
So I agree. It's a large jet. It looks like it's about, so I'll try and be systematic. It's a large central jet on the apical four chamber that's hitting the posterior wall, not associated with dilatation of the annulus, I don't think. And if I was to just eyeballing, it looks like the vena contracta is going to be quite wide, and it looks like the regurgitant volume is going to encompass the atrial size. So I think it's probably on the more severe side.
What would be, so you mentioned a few things in there, what would be the signs of severe regurgitation for you in terms of 2D, color, continuous wave, pulse wave, Doppler? What are your markers for severe MR?
So I'd want to look at the left heart and the right heart, and I'd want to be looking at the pulmonary pressures.
Cool. So raised pulmonary pressures, yep.
Yep. So pulmonary pressures. On 2D, we've talked about left atrial dilatation,
yep.
And the annular morphology. Yep. On continuous wave, so using pulse wave, I'll be looking at the pulmonary veins and see if I could image the pulmonary veins and look at the SD, looking for diastolic reversal.
Or diastolic reversal.
So looking at the S and D waves.
Yeah. So hang on, regurg is in.
So diastolic, not diastolic reversal, but I'd be looking for a, what's the word?
Systolic?
Dominance. Yeah.
Yeah, so systolic reversal.
Systolic dominance.
The regurg is in systole. So normally it's the S wave is bigger than the D wave in your pulmonary veins, and if you get horrible regurgitation, the systolic one can go the other way. So it's because the regurg is obviously happening in systole and pushes the blood back out of the pulmonary veins. So you get systolic flow reversal in your pulmonary veins.
Yeah. Cool.
So just in the meaning of time, we'll just blitz through them again. So if you've got 2D signs, you could talk about raised left atrial pressure. So, big left atrium, interatrial septum pushed over to the right. In terms of color Doppler, you'd have color Doppler filling the left atrium, hitting the back wall, but that's load dependent, right? Then we're going to talk about pulse wave, then continuous wave Doppler. You'd have a big parabolic, really filled in jet that can suggest a lot of blood flow that's going into that left atrium, but it's angle dependent, and it depends. If you've got an eccentric jet, it maybe underestimate the severity. Next thing, you could do pulse wave Doppler, looking in the pulmonary veins, looking for systolic flow reversal and with raised left atrial pressure. Again, if it's eccentric, you got to pick the right pulmonary vein. And then the last thing I'd say is the pulse wave Doppler. If you've got a really big E wave in the mitral inflow greater than 1.2, that's pointing to severe, as long as you've got no mitral stenosis. And then you can do with your pulse wave Doppler and your continuous wave Doppler, you can estimate what the orifice area is and what the regurg volume is, and severe is all greater than 60. Okay? So let's try and get those to rattle them off for the exam, okay?
Yeah.
Prof, how do we treat this? What do you think about this?
Well, I guess the important thing really is to get a little more definition, because we have our suspicions, but the treatment can vary quite a lot depending on whether you're dealing with mitral stenosis from rheumatic cause, which means it's chronic. And all you'd have to do, what I would normally do in that situation, is treat the woman with diuretics and try and sit it out till the end of pregnancy with a view to fixing up the valve after the baby's delivered. If it's not that, it's antiphospholipid syndrome, then you're dealing with something a little more sinister, because it's not going to remain stable between now and the end of the pregnancy. It's going to become a lot worse, which means that valve, which is pretty bad now, could become a lot worse. So we need to get more definition of that mitral valve. So I would progress and do a toe next.
And what do you think of these? So this is your toe that you did, Prof. What do you think?
First of all, it shows that the mitral leaflets, the one on the left, for example, they are rather pliable. They're not fixed. They're not calcified. It's not rheumatic. But what we can see are these actually rather large masses at the tips of the leaflets. And so now we are becoming a little more confident that we're dealing with antiphospholipid syndrome and Liebman-Sachs endocarditis. Putting aside the severity of the mitral regurg, which I agree is severe, we really have to find out a little more about those masses. But I'd like to point out, although as Sam has pointed out, if you're going to use the mean gradient across the mitral valve, it would suggest that's bordering on severe mitral stenosis. But when you look at that left one there, that's not that stenotic. Sure, there is a degree of stenosis, but it's only mild. But remember, this is only a 2D picture, so we need to look further at those mitral leaflets. Look at the gastric views there.
No, I just did
Okay. Yeah. So the reality is that looks very much like Liebman-Sachs endocarditis. Now, somebody made the comment before that if you have this, it's common lupus. The reality is it's more commonly associated with lupus because there's more people around with lupus. But in fact, your chance of having valvular dysfunction with Liebman-Sachs endocarditis is actually higher in antiphospholipid syndrome than it is if you've got lupus. It's about 25 to 30% of people will have some degree of valve involvement. More importantly, the valve involvement, it comes under the category of non-infectious endocarditis. And of course, the other DD here is not actually endocarditis, but is it a thrombus? Are they just thrombus? Because we know with antiphospholipid syndrome, you're more likely to have a thrombus. So are we just dealing with thrombus here? Well, the answer is no. These are actually classical shapes of Liebman-Sachs endocarditis in antiphospholipid syndrome. They're got some degree of independent motion, not a lot, but the big chunky pieces of tissue that are adherent to the mitral leaflet, it's due to inflammatory changes. If you chop them off and look at them under the microscope, you will find it's all inflammatory. And there is a difference, in fact, interestingly enough, between the histology of that found with Liebman-Sachs and antiphospholipid syndrome compared to that found in lupus. There is a difference in the inflammatory picture. Having said that, that's all a little esoteric. The reality is this woman's in big trouble. If they continue to grow, she will just wreck that valve completely. And by the end of the pregnancy, she may have no valve at all. The question here is, what do we do? We've really got 4 options. 1, do nothing. Number 2 is the only treatment, conservative treatment that's shown to be effective is anticoagulation. Number 3, can we actually have those masses removed from a percutaneous procedure? No, the real sharp guys around Sydney that I know say they can't do it. And so D, that leaves surgery. And I'd be very reluctant to go to surgery in a 25-week pregnant woman because in this situation, you'd be unlikely to get away with valve repair. It would be valve replacement. So at this stage, the treatment is to treat her conservatively on a weekly basis, follow the size of those masses and see if at least if they don't get large, if they don't improve, to make sure they don't get larger.
Can I ask a question about if we think they're vegetative in appearance, what excludes endocarditis, about bacterial endocarditis?
Because if you use the classification, you need positive blood cultures.
Okay, so it's only the lack of positive blood cultures that allow us to say that this is not bacterial then? Question mark.
Not only that, if you had positive blood cultures, it would really make it murky. But it's the classical appearance, these sort of chunky vegetations that sort of blend into the leaflet itself. They're not sort of sitting off independently, although we have seen other ones. They're really chunky masses that are really adherent on the mitral leaflets.
Yeah, I hope you guys can all see this. I mean, particularly this, the tips of the leaflets here, particularly on the posterior leaflet, it looks like it's got independent motion, right? It looks like there is it doesn't look like you've got the whole, thickening like you'd see in the mitral stenosis with a hockey-shaped stick appearance to it. This looks very much just like a tip, and it's an independent thing that's stuck to the valve with independent motion, right?
So
I mean, sorry, I was going to say the hallmark finding is commissural fusion with rheumatic MS. So that's mostly what you look for.
Yeah, good call. Excellent. Yeah, absolutely. I'm sorry, I should have shown the short axis. It wasn't great, unfortunately. I think she was quite a tricky toe.
Yeah, and the interesting thing is, which we don't see on the short axis here, is in fact those masses, and one's I think 18 times 10 millimeters, and the other is about 12 by 9 millimeters. They are both plonked right in the P2 and A2. They're not in the A1, A3 or P1, P3. They're right smack in the middle of the leaflet. So it's a very well defined location of the masses.
All right, well, I'll tell you what the meaning of the word time. Let's just go through everyone else and we'll try a few more. Is there any more questions for Prof about this case?
Just a quick question. How common is aortic valve involvement with the mitral as well? Like if it's Lehmann-Sachs?
The aortic?
Yeah, with the mitral. Could you see it? Because if it's a flow dependent, like vegetation and inflammation stuff going on.
So I don't quite understand the question.
So is aortic valve involvement common as well with mitral?
Yes, mitral is probably the most commonly affected valve with syndrome, Lehmann-Sachs, but the next one is the aortic. But generally it restricts itself to one valve for reasons that really are not understood. Yeah.
Cool.
Does that answer your question?
Yeah.
Yeah.
Thanks very much.
I want to say, folks, that this is a pretty rare finding, very uncommon finding in a pregnant woman. It should be pointed out that she was known to have antiphospholipid syndrome. She refused to take Clexane from week 12 of pregnancy because she felt uncomfortable with it.
Silly girl. All right, guys, let's do the next one. So who's up now? Sid, hi, buddy. Where are you calling in from again, Sid? I'm just going to unmute you. You ready to take a case, Sid?
I'm from Darwin.
Yeah, hi, Sid. Are you ready to go?
I don't know. I can try, give it a go. I'm very early in this DDU, so.
Well, let's see how we go. And it's and we're starting off with you because I think it's we'll start off easy and then we'll get harder. Don't worry. You don't want to be at the end. You want to be at the beginning. Cool. Okay, so here we go. So last Tuesday, you got an urgent call to recovery. 31-year-old girl. She's just delivered twins. She's on the way to recovery and she gets sudden onset shortness of breath. She's tachycardic, normal saturation, and hypotensive. She's got a background of preeclampsia and a flu-like illness. I've used this in other talks, so excuse me, you've got other things in here. So just the blue one in the middle is what she's got. So
Well,
I used this in another talk. So here we go. What do you think?
it's a parasternal long axis view. Very pumpy kind of pictures. Not very well established endocardial borders, but patient is obviously very tachycardic and the walls are kissing each other, probably I don't know whether underfilled or peripherally vasodilated or something like that.
Very nice. She's just delivered birth. Yeah, she's tachycardic and hypotensive. So absolutely. So give me other causes of shock, which you've got to exclude. I think just finishing off your description, you're absolutely perfect so far, but finish off the description in an efficient manner.
This is a pregnant state. Obviously, they are usually hypervolemic, but in this state, it could be a hypovolemic shock. Myocardium, cardiac contractility, the LV contractility as such looks fine. There's no regional formation abnormality which I can see in this view, but probably is a hypovolemic shock.
Beautiful, and I agree. I just think all I was meaning to finish it off is just differentiate other causes of shock, because you've got to make sure you'd say that the RV isn't dilated. You know, we have got no, you know, there doesn't seem to be a, so I guess if you're talking about causes of shock, which can have this kind of profile, it could be the vasodilated type of shock, of course, from sepsis or something. It's a bit unusual with the clinical presentation. But the big things, I think, with someone who's suddenly short of breath and hypotensive and tachycardic, we've got to be thinking about hypovolemic shock because he's just had a C-section for twins. And we've got to be thinking about something like an embolus, whether that's amniotic fluid or PE or something like that, okay?
It'll be important to see the right heart functions, I think.
Beautiful. That's exactly what we want to hear. So keep going, man. Does that back up what you're saying? You're saying that she looked hypovolemic with a normal sized right ventricle?
I can't really make out what view is that. Is it the short axis view of at the papillary level? Is that what it is?
Yeah, sorry. This is meant to be a short axis view. And excuse me, I didn't say sorry. This I'd used these things in a different lecture. The people who didn't understand echo, so I put a normal picture in this bottom right-hand corner. This is not the same patient. The big one is the patient is the one in the blue in the middle. Sorry if that wasn't clear.
Yep. Yeah, that's fine. But again, the septal walls, I can't really make the septal walls. If I'm looking for the D-shaped septum, if I'm thinking of the RV dilatation or the embolism, I can't see the D-shaped septum or the bouncing of the septum.
So supporting your theory that we're dealing with a hypovolemic state.
Yeah, but I need to see more views to look for the, like say, TAPC or the S prime or at the lateral wall of the.
Beautiful. Just 2D pictures with a lot of this, I'm afraid.
Pictures, yeah. Well, in this view, the RV size looks smaller than the than the left side. But again, the left ventricle is contracting very well.
Beautiful. So again, it's talking about the left ventricle size, the left ventricle function. Don't forget to mention the valves. So I guess the pattern would be, you know, apical 4-chamber view, small hypercontractile left ventricle. Both ventricles appear small and hypercontractile. There's you know, a pseudo hypertrophy. The walls look thick because of a potential hypovolemic state, and this with a tachycardia. I think don't forget to mention the rhythm down at the bottom. So again, just keep, when you're trying to report these in the exam, you know, a quick, you know, executive level thinking with the stem of the question is obviously what it's all about. So someone who's got sudden onset of shortness of breath and sudden onset of hypotension, you know, we'd be saying that we'd be talking about hypovolemic state, probably looking at this echo with someone who's significantly tachycardic. I'm sorry, I don't have the heart rate in there.
Yeah, sorry.
Right.
I need to explain it in a better way, obviously.
That's fine. That's just that's what this is all about. I just sort of giving examples. And lastly, here's some lung ultrasounds. What do you think in that?
Probably fluid overload because of all those B lines, is it? Which I can see.
Yeah, nice. So, so I think again, be careful about the terminology. You said fluid overload, but everything that we've just had has suggested that she was hypovolemic, right?
Yeah. Yeah.
So I think all you can say is say what you see. So tell me, you said she's fluid overload. What are you seeing here? Why are you saying that?
So I can see those, but it's only one probably B line which I can see from top to bottom. You need to see few more than just one, I think.
Yeah, sorry if it's not coming out well. There are meant to be some more than 3 B lines in all of them, to be honest. Yeah. I've got the right side up here. We've got a few coming out well.
But if the patient is if I'm suspecting hypovolemic shock with echo looking, the lung ultrasound looking like a fluid overload state, think about what could be the cause of it, whether there's some pneumonic infiltration going on, I don't know.
Beautiful, beautiful. Don't forget to see, in both of these cases, I'm describing the idea is you've got to see the whole heart is the term I sort of bring up again and again and again. You know, it's in context and taking that whole picture together. So with this, the B lines, I guess, talking about a fluid overload state, I'd argue that absolutely you can see this in a fluid overload state, but all this is showing is a sign of increased interstitial fluid. And in someone who's got this underfilled tachycardic heart that looks like, that could be the cause of the hypotension. Again, don't forget to see everything in there. Looking at this, this is not sinus rhythm that's going on here. And I guess if you're seeing these two sort of separate patterns, I think this has got to point us to thinking that we've got some other kind of pathology. This is not just hypovolemia, which is going on. And I think this lady's got a supraventricular tachycardia that's giving her a heart that's working overtime, giving her pulmonary edema, and this is an indication that someone, we need to get her back into a sinus rhythm. So some adenosine and everything kind of goes back to normal. And it's just I think it's a nice example of, I think we would call the anaesthetists very much a sort of fixation bias. Just, they had this fast heart rate and this underfilled heart, and they jumped straight to thinking about the amniotic fluid embolism. And I think this is something that's, go with first principles of everything. So nice, Sid. I think just in terms of talking through all those pictures, again, to say what you see, nice systematic approach. I love that, the kind of things that you were saying where, if we do show you rubbish pictures, like some of these that I've taken in a rush, you're totally fine to say, I can't get all the information, I need other views. And I think the other nice thing you said is, if you've got an abnormality, I want to see another view to go and back it up. So talk about left ventricle size and function, left atrial size, do the valves look okay? Is the right heart big? In this story, I think it's really important to say what the biventricular size and function is like, okay?
All right.
Cool, thanks, Sid. All right, Ravi, do you want to go next, mate?
Yes.
Sweet. All right, what's the next case? I want to see. So we've got an Aboriginal 17-year-old girl. She's had an urgent C-section for fetal distress. She's 39 weeks and she's been tachycardic and dyspneic for 24 hours. Increasingly shortness of breath and hypoxia leading to intubation. And she's now hypotensive with low saturations with pulmonary edema. They're unable to extubate her after the surgery, and she's transferred to the ICU. So if you're given that stem, I want you to approach, what are the things you've got to be thinking in your head before I even show you any echo pictures?
So pulmonary edema is based on clinical.
Yeah. So it's all based on clinical stuff. So if you've got, someone who's having just had a C-section for fetal distress, she's been a bit short of breath, and she's essentially got worse. Now she's hypoxic, she's got crackles on her chest x-ray, they haven't been able to extubate, and she comes to ICU, what differentials would be going through your head? Because because with that differential, that's then how you have to go and report the echo. Because I don't want like a standard approach where, for this one, for me, it might not be so much about the right heart, for example. So I think you've got to think how you're going to give me the differential diagnosis, and that's what's going to guide your discussion.
She is Aboriginal lady, so the differential still could be wide, and it could be a precipitation of a pre-existing disease.
Nice.
Or something new that has happened, and she could have left heart dysfunction leading to all these, or there could be some underlying valvular problem which was unrecognized and has got unmasked with her full-term pregnancy. Apart from that, there could be an element of infection, which could have precipitated her underlying cardiac problem.
Yeah, and I think with this subacute, we've got a 24-hour history that's coming in there with then deterioration during the actual procedure. So you've got a subacute process that then's kicked off towards the end of pregnancy, which again can guide you thinking, as you were saying, about the peripartum cardiomyopathy, if there's some kind of aspiration or something else that's leading in there. Okay, so there's her chest x-ray. And let's go into the echo.
So it's
a normal echo down in that bottom right corner, and here we've got the echo for the 17-year-old Aboriginal.
Okay, so that's a parasternal long axis view. One of them is 2D and one is the Doppler, color Doppler. So the plain 2D view shows, just from visual impression, it shows a dilated left atrium. The mitral valve looks like hockey stick appearance of the anterior mitral leaflet. And there might be a restricted opening of the posterior mitral leaflet. On the color Doppler, I can see a mitral regurgitation, and also turbulence across the mitral valve. Also, what I think is the left ventricle looks a bit dilated, but we don't have the measurements yet.
Very nice. Very nice.
The right ventricle appears to be dilated, but we don't have measurements again. And the aortic valve seems to be thin. There's no calcification on the aortic valve. And I can't see the Doppler on the aortic valve like very clearly.
That's really nice, Ravi. That's excellent.
From what I can see, there is no aortic regurgitation there.
Yeah, very nice.
Also, I cannot see any pericardial effusion. And, there is more lung window there, but I can't see any. I'm not sure whether we can see any B lines there.
It's a really nice systematic approach to it. I like you going straight for the money, talking about the thickened mitral valve leaflets with the hockey-shaped appearance. I think we talk about the color Doppler that's got this, chaotic, almost flame-like appearance of it shooting out, suggesting possible stenosis. You got significant regurgitation into a dilated left atrium. And then you talked about the left ventricle size and function, right ventricle size and function, no other causes of shock. That's beautiful, Ravi. Nicely done. Just in the meaning of time, let's, I think, because we kind of gone through some mitral valve stuff already, I guess this was quite nice to show in addition to the other one, because the antiphospholipid lady, can I persuade you that it looks very different to this one? This is a lady who's got rheumatic fever mitral stenosis that's there with this commissural fusion and leaflet, whole leaflet tips that are thickened, as Lewis was talking about. And this is pointing much more to the mitral stenosis from rheumatic fever rather than the antiphospholipid syndrome, okay? Big.
So that looks like Sam, that looks like the short axis looks like the fish mouth appearance.
Absolutely. And sitting there, the fish mouth there with a baby blowing a kiss that we often see in the, that's more pathognomonic for for rheumatic fever mitral stenosis, right?
Yep. Very
nice. And I think, we'll keep moving on just in the meaning of time. Very nice. Cool, Ravi. Thanks, man. Who is next? Who else do we have? Do we have anyone else online? Hatim, are you there still? Hatim, do you want to go next?
Yes.
Okay, so we've got a 26-year-old girl, elective C-section with a spinal, G1P1, shortness of breath during the procedure, hemodynamic compensation, loses her output and CPR started, and you're called to come and do the echo. What's going through your mind?
So again, pulmonary embolism, amniotic fluid embolism, anaphylaxis, peripartum cardiomyopathy, so wide differential at this stage, hemorrhagic shock.
Very nice.
So this is a parasternal long axis view showing its poor view, but this is what we can get at this stage. This a plain scan without Doppler flows, and this confirming presence of decreased LV size and function with left ventricular hypertrophy, decreased size of left atrium. Mitral valve doesn't appear to have any major pathology at this stage. Aortic root looks again mild dilated, but again doesn't show any major pathology. There is enlarged right ventricle in comparison to the left atrium with septal deviation that can be identified. So I'd suspect that the pathology here would be consistent with right side failure, whether it's amniotic fluid embolism or pulmonary embolism.
Very nice, Hatime. I like the way you go through that. My only comments would be that the two things I've written down is the LV hypertrophy. You've got to be careful when you call about hypertrophy in an underfilled left ventricle.
Yeah, exactly.
We can talk about it. You need to, if you want to say hypertrophy, I think we'd be saying, you know, in an underfilled heart, that someone very sick like this, you're worried about pseudo hypertrophy. It's the same as if you look at a heart in, you know, in a cadaver after you've been to an autopsy, right? Everyone looks like they got hypertrophy when there's no blood in the heart because the heart all sort of everything sort of flops open. So we talk about pseudo hypertrophy, it's hypovolemia. You just got to be careful of calling that when someone's got an underfilled left ventricle.
Yep.
I've also written down, you know, RV first. You know, I think if someone is having a cardiac arrest and in there, you've don't forget to look at everything, but go for the money first of all. You know, the striking feature for me in this is that
the RV
is the RV, and the fact that the LV's hardly doing anything now. You know, there's dyskinetic motion almost, and you can imagine that the cardiac output would be terrible during this. And absolutely, that's in keeping with, as you were saying, the amniotic fluid embolism or the pulmonary embolism. Yeah, nice.
So this is, yeah, this is an apical four chamber. Looks like I can't really identify the aortic opening. So apical four chamber view, again consistent with massive right ventricular dilatation and septal deviation and diffuse hypokinetic function of both ventricles with dilated right atrium. Nearly encroaching the whole of the left atrial space. I can't see any pericardial fluid, and its right ventricular apex is the predominant as well.
Yeah, and what do you see in the right ventricle? Talk to me about what's in the right atrium and right ventricle.
So this would be signs of pressure overload with marked dilatation of the right ventricle. It's nearly double the size of or at least 1.5 times the size of the left ventricle. There is massive dilatation of the right atrium as well.
And do you see anything floating around in it? Sorry if it's not coming out well. I'll have to describe it otherwise.
Yeah, it's not clear for me, but
it just looks like there are lots of bubbles that are just kind of swirling around. And I guess, I'm sorry you can't see. I'm sorry it doesn't come out well. It's like, I think we took this off a phone during the resuscitation off the bad sonocyte they had in there. Basically, it's just showing very sluggish movement of what looks like bubbles. And I think the differential diagnosis for that would be either it's, you know, fluid that we're pumping into her that's just got very sluggish blood flow. It could be amniotic fluid embolism. It could be pulmonary embolism and actual blood clots swirling around. And it could just simply be set because you've got a cardiac output that's about 0.1 or something. So, yeah, terrible sign of prognosis. And again, you talked about the interventricular septum being pushed over as a sign of, with this would be a sign of cor pulmonale in these circumstances. Nice. Okay, should we just do a couple more? Who are we back to? Vishal, do you want to
go? Yep.
Beautiful. So 34-year-old lady, 35 weeks pregnant, first bub, hasn't given birth yet, increasing shortness of breath as she comes into ED and because it got acutely worse. She's got a sinus rhythm, tachycardia, saturating at 88%, and she's got type 1 respiratory failure with a normal blood pressure. That's a chest X-ray?
Yeah.
Ooh. Oh, great.
Do you need me to zoom in on them? Are you okay?
No, I'm good, thank you.
Thanks.
Otherwise, it would be too big. So, so parasternal long axis. So on the right upper corner. So the main thing, you know, is catching my eyes. The right ventricle is very dilated, and the ventricle cavity, the left ventricle cavity looks small, so maybe patient is underfilled. But there's multiple B lines I can see on the lung window on the same axis. Otherwise, mitral valve. I need to slow it down, but I'm concerned about dynamic alveolar obstruction here. But it's not clear. But I need to slow it down.
Okay.
And in the short axis, so our right ventricle is very dilated. You can see the D-shaped, septum. So there's, again, I need to slow it down whether it's only volume overload pattern or it's volume and, pressure overload pattern. And again, in the apical 4-chamber, the, very dilated left ventricle, left atrium, and the,
very dilated left ventricle, left atrium?
Right atrium and right ventricle.
Thank you.
Excuse me. And with moderate TR on that. So basically, I'm concerned about acute cor pulmonale here because, very dilated right side with moderate to severe pulmonary hypertension and all the features of cor pulmonale, including D-shaped septum and dilated right ventricle and decreased right ventricle functions.
Yeah, nice. And again, I think the diagnosis, so that's really nicely done. Good systematic approach, going for the money first and not forgetting to talk about other things when you're talking about shock. So I really like the way you go straight for the RV. And I think whenever you're mentioning anything on the parasternal long axis view about the right ventricle, always, be a bit humble with it and suggest we need other views to go and back up our conclusions. Few little tips and tricks. I guess you talked about LVOT obstruction. She doesn't have that on this one. The way I do this, see if I can play that. The way I train my eye to do it is I try and look at the anterior mitral valve leaflet out of the corner of my eye. Can you see my cursor?
Yeah.
So I put my eye where that cursor is, and I look at how the walls, when the walls move together, obviously that's systole. And out of the corner of my eye, I can look at the anterior mitral valve leaflet, and I can sort of pretty quickly then get the idea that as that ventricle contracts, that leaflet goes down. So it's of course, you're not saying if you can, you've got to pause it and slow it down, but that's sort of the way I it's a bit of a trick, or just actually look at the septum and you actually get an idea that when that's thickening, there's no LVOT obstruction. And I use that same principle when I'm looking in the short axis to see if you've got the septum moving or not. I don't look at the septum to figure out when it's moving in the cardiac cycle. I look on the other side. I sort of put my eye on the middle there, and when that's contracting in, I can see that the other septum sort of bows out of the corner of my eye.
Okay.
I don't know if anyone else has any other tips and tricks, but that's sort of that's the way I do it. And again, I want to back it up in other views. So I can look here, I use my eye on the tricuspid annulus moving, and as that's moving up, I can see there's a little bit of shifting of it. So that points me to think that it's D-shaped throughout the whole cardiac cycle, I think, but the biggest section is during the diastole, suggesting that there's a volume overload component to this. And then the last thing to say is when you're talking about cor pulmonale, for me, cor pulmonale is not just an echo diagnosis. It's also a clinical diagnosis of someone whose right ventricle is unable to cope with is unable to cope. And so you've got signs of systemic congestion as well. And in this case, a lady who's acutely shortness of breath with tachycardia and hypotension, this is someone whose right heart is struggling. So it's the clinical stuff, not just the echo pictures, to diagnose cor pulmonale, okay?
Sounds good.
And she had a bloody great PE that was sitting on there. Lewis, do you want to do one more? Why don't we have one more from Lewis McLean?
Yep, sure.
All right, so case 5, 32-year-old lady, G2, P2, 6 weeks postpartum, severe dyspnea. What could be going on?
So this is not peri-procedural, but I'd be still thinking, and she's a fair amount of weeks postpartum, but I'd still be thinking about pregnancy-related issues. So cardiac and non-cardiac, she can still have a pneumonia, she can still have preeclampsia, she can still have asthma, etc.
Yeah.
Specific to pregnancy, she's within the presentation period for a peripartum cardiomyopathy.
Very nice.
She could still have a PE. She won't have an amniotic fluid embolus. But
cool. So how about this? What do you think about these echo pictures?
So I
Why don't I just give you a little bit of zoomed in? So I'll
Yeah, I
give
think
you
they're a bit small. Okay, so there's an echo-free window in the anterior pericardium, suggestive of pericardial effusion, and that's seen posteriorly as well. I'd like to measure that. The RVOT looks about equal to the left atrium, and sorry, you want me to be more systematic?
Yes.
So I'll go for where the money is. It looks like there's a small to moderate sized pericardial effusion and left ventricular dilatation with probably normal to slightly thin walls. So suggestive of dilated cardiomyopathy. The EPSS looks like it's significantly reduced. So I'd eyeball the ejection fraction at maybe 15%. I'd confirm in other views.
Acute, chronic?
Difficult to say. The walls are not super thin, so it's not a grossly dilated cardiomyopathy, which makes me think it's more likely to be acute. The presentation is consistent with an acute process, and given the left atrial size,
Nice.
yeah, consistent with an acute process.
Beautiful, yeah. The left atrium, I can't remember who you told me to. The left atrium being the HbA1c of the heart. Yeah, beautiful. So if you've got a raised left atrium, you've got to have some kind of raised left ventricular and diastolic pressure that's been there for at least a few days, if not longer. So it's probably not an acute process. And I agree with this story of being around pregnancy. We've got to be worried that this is a peripartum cardiomyopathy. And these can occur after pregnancy. I imagine if you've got through pregnancy with no problem, it's unlikely that it's been a chronic issue. I think we're dealing with a subacute acute process. And I guess just in terms of how you were structuring the answer to that question, I think probably the left ventricle is the money here. Mentioning the pericardial effusion is important. And you mentioned things like the EPSS, and if you're going to mention these, you know I'm going to ask about it. So you asked for a measurement of the for the pericardial effusion. How would you measure it? And if I told you the value was 1.1, what does that tell you?
So I'd ask you if you'd measured it in the largest echo-free space.
Nice. And at what stage in the cardiac cycle?
And in, I keep getting myself mixed up between systole and diastole. I'm trying to be less dyslexic.
It would be the one when the heart's the biggest, so it's end diastole.
Yeah.
So it's
diastole,
diastolic measurements in the biggest space you can find. And what are the cutoffs for small, moderate, and large?
So 0.5, less than 0.5 is small, 0.5 to 1 is moderate, and then larger than 1 centimeter is large.
1 and 2 are the numbers. So more than 1 centimeter small, 1 to 2 moderate, greater than 2 large. End diastole, largest space you can find.
Got it.
Cool, nice. And then you need other views to back it up, and you can see throughout all of this, she's got a dilated heart. I think if you've got someone who's got a shitty heart, got someone who's got some kind of decreased cardiac function, talk about regional wall if you can. And I think you're seeing a global phenomena which more sort of points towards a peripartum cardiomyopathy. Okay. Last thing is you said EPSS. What does that mean, and what values would you be interested in?
So that's an M-mode measurement through the tips of the mitral valve. It's essentially a screening test for reduced systolic function. So given probably not appropriate to mention in this context because the LV is so clearly down. But you're looking to see it's the E-point septal separation. So it's how close the mitral valve gets to the septum in atrial systole.
Nice. So, or ventricular diastole, yeah, beautiful. So,
Yeah.
The maximum point that anterior mitral valve leaflet is towards that septum. And what's your cutoff for normal?
7 millimeters.
Very nice indeed. And just for interest, this is her 25 years later. And I think I've made a typo there. Sorry, it's not 25 years later. I think it's 2.5 years later. It's not a lot better, but here you can also see regional wall. I'm sorry, not normal. I mean, that's and she had a normal angio. All right, guys. I think that's probably time to call that. I guess just in summary, I guess these cases are all about the stem being super important, and when you're talking in the exam, it's that executive level summary. And what I mean by that is it's very much you've got to link in what's happening in the echo with what's happening clinically. So grab that stem, and before you start answering your questions, get that differential in your head, and then try and go for the money whilst being systematic, particularly at the beginning of when you're starting to talk, being a systematic approach that puts, the examiner at ease that you're not going to miss something, and go for the money and, sharp, efficient communication, not saying ers and ums, and just, slick presentation, I think is the go, all right?
So Sam, could I just clarify, you have 40 minutes, 8 questions, is it 8 cases?
That's right, yeah. So 40 minutes, 8 questions. Oh, that's 40 minutes, as many questions as you can get through. Normally I've got, normally we've written like sort of 8, like this year we had, I think it was 8 questions that we'd written ready to go. For me, I think only one candidate got to the 8th question. We just want to make sure we don't run out of questions. How about that?
And we're viewing these on a laptop, is that right?
Great question. I'm sorry that wasn't clear. Yeah, so in the exam, the moment these exams are taking place at it's a place in the middle of town near Chatswood, which is like an exam center. So it's not set up for echoes. Yeah. You'll be looking at it on a screen that's about 21 inches wide. And it won't be like this. I'll try and give you individual images so it fills the screen. Sometimes you get sort of 2 on one screen. And classically, the cases, the longest case would be, maybe 8 slides. The shortest case will just be 1 picture, and it's a point and shoot type answer. And it will be on a laptop. You won't be able to pause it and scroll through. We give you a pen to point at things on the screen. You will have at least 2 examiners, and sometimes there'll be, I hope we're getting more examiners on things, so you might have a 3rd examiner in the room. And we get 40 minutes, and you're expected to get through at least 5 questions. If you're super slow, the examiner will speed you up, and that doesn't mean that you're getting things wrong. It just means that we've got to get you through at least 5 questions or you're going to fail. It's that kind of thing. Okay. All right. Yeah. Were there any other questions?
No. Who's going to Melbourne?
Say again?
Who's going to Melbourne? Anybody or?
For the ASUM?
Yeah.
Yeah, I'll be there. I'm talking on the Friday. So yeah, I'll be down there just for the Friday.
Oh, great. Okay. Catch you then.
Nice one, guys. All right. Well, take it easy. I'll talk to you soon.
Great. Thanks.
Thank you. Thank you, Sam.